Hi, this is Dr. Scott, and I'm going to record this lecture that I'll put up on YouTube first, but hopefully we'll save it and it will be reviewable later on in this course when Kaltura catches up with us. You have to start somewhere in anatomy and physiology, so we're going to start with the very basics on gynecology assessment, okay? There are 6 objectives here, so this one is a little bit detailed. It's not a long lecture, but it's sort of detailed here. I want you to know the major components. This is not an A&P course where I'm going to put up a picture of a pelvis and actually ask you to name every tiny part of the bony pelvis, but I want you to know the major ones, okay? I think it's essential to women's health and women's health nurse practitioner for you to understand how the pelvic organs are supported, because loss of support is something that we treat a lot. Name and recognize the components of the vulva, because this is what you're going to be looking at for the rest of your career, okay? And it's important that we really know how to label this. Basic female anatomy of your reproductive organs, internal, and looking at the anatomy and function of the breast. If you are interested in your career, you can go on to become a lactation consultant, but certainly every nurse practitioner in women's health ought to have a good basic understanding. And then the little bit harder part for myself is the endocrinology behind the menstrual cycle. Okay, so reproductive anatomy is female anatomy because we're the only ones that can actually reproduce, right? And gynecology is that branch that deals with this. So looking at this pelvis and these major components, when folks are forensic pathologists and forensic folks, they can tell if a bone, the pelvis came from a male or female, if this person was male or female, just by the pelvis, and they use this a lot. You can also tell it from some of the other long bones, whether they were male or female, but the pelvis is one of the easiest ways that forensic folks tell about this. We have the Body Farm at UT. If you've never read any of those books, at such time as you can read for fun, they are great books by Dr. Bass. So he runs the Body Farm, and they study bodies, in various decompositions. So they use the pelvis in determining gender. So the pelvis has these 2 hip bones, and the only things that are called the innominate, meaning no name, they didn't have anything else to call it, so they called it the innominate bones. These are fused, and those are the hip bones, okay? And the sacrum and the coccyx, of course. Now the innominate bones are the pubic arch, ischium here, sits bones. You'll hear fitness instructors call them the sits bones, it's the ischium, and the ilium, where you all learned how to give IM injections by identifying the iliac crest. So this is the pelvis. So an ideal pelvis is designed to what? Get a baby out through there, right? Okay, to get a baby out through there. So there are these basic 4 pelvic bony types. And many older gynecology and obstetrical, particularly obstetrical texts, wax eloquent about the importance of knowing how this woman's pelvis is shaped. Is it anthropoid? Is it android, platypoid, or gynecoid? And those are certainly types. And if you were at the Body Farm and looked at different types of female pelvises, you would certainly notice that, okay? But I will have to tell you, as a matter of practicality, when your subject, your patient, is attached to living bone tissue, fat, tendons, and all manner of other things in that pelvis, it's not so easy necessarily to distinguish each type. But in looking through this, we'll start here. The android on the right has sort of a heart shape, if you will. The platypoid Like a platypus, it's more of a flattened, equal anterior and posterior. And the gynecoid is more rounded and equal anterior and posterior. And anthropoid is less posterior, more anterior. The gynecoid pelvis is the most ideal for birthing babies, but most really are of mixed types. What does that matter? Well, you will be happy to know, as future women's health nurse practitioners, you don't have to identify all of those structures. The diagonal conjugates and the ischial spines and all of this that you go over in your books, you may or may not need to know it to pass some of the boards. I don't know. Personally, as a midwife, I'm not a midwife. They may need to do more of this. But these two studies showed there's really no routine need for measurements. It is not, and I hate to burst everybody's bubble, but it's not predictive of their ability to deliver. Now, if you have a true, what they call contracted pelvis, such as an achondroplastic dwarf, okay, we're not going to let those ladies labor, obviously, that's not going to be a good thing. But in normal, otherwise normal-sized women, just let everybody labor. If they're progressing, let them keep going. So these are two articles in there at the end. The one horror, though, I will have to share with you, because I think you need to know, the one horror in not having a crystal ball regarding pelvic type is with cephalopelvic disproportion, where the head can't get through, or worse, still much worse, is shoulder dystocia. You get the head out, and any of you have ever worked labor and delivery, I hope it's not happened to you, but chances are it may have happened to you to some degree. That head gets out, and that turtle sign comes, and that head gets sucked back, the neck is sucked back up in there, and you just cannot get that head out. The head out, you can't get the shoulders and out. Breaking the clavicles will do it. You try to deliver the posterior shoulder. It is an absolute nightmare. The worst outcome for this is a thing called a Zavonelli, Z-A-V-O-N, Zavonelli, where the head is actually pushed back into the pelvis and baby's delivered from above. As you can imagine, that almost never goes well and never has a good outcome. So even though you measure, or try to measure though, the real truth of the study and the evidence is that you can't predict when this would happen. Oh, let's breathe. Now, pelvic support. This is an important deal. Looking at this picture on the right, just looking down at it, so you're looking down from above, it kind of looks like some slings, okay? Kind of looks like some slings there. So the pelvic support is not just the muscle, but it is also the connective tissue. All right? So it is a combination of many. And when you're looking at plain anatomy and physiology, the deep perineal space is the pouch there on the perineal membrane. This diagram does not show that as well as some of the others in your text do. And it talks about the perineal membrane and the supporters there. I'm most interested, though, that you understand these things called the levator, as in elevator. Okay? These, when contracted, elevate the pelvic floor. And then the fascia has a supportive sling. Okay? So when we lose support, when large babies come through there, etc., or protracted straining, even at stool, you can understand that these muscles get stretched beyond their capacity, and that sling that normally supports the urethra can have laxity, thereby producing stress urinary incontinence. It's important to explain that sometimes to patients. The levators, I often will just take my fingers together and interlace them and explain to them how it elevates the pelvis, especially when you're trying to teach them Kegel exercises, etc. Now these two 3D presentations are excellent. It took me a while to find them. They're excellent. The first one does have one little offensive word in it. I just would warn you. It's not horrible. It's not the most offensive, but it is a little bit. But it uses humor in helping you to remember some of the things and helping you understand the function. So I would encourage you to look through those. Now, what you're going to be looking at most is the vulva. There are a lot of arrows over there on the right. No, you're not going to have to label every one of those on the test, so just, relax a little. But I want to point out, you got to name things. So when you're charting, if you have a lesion somewhere or if you do a biopsy, you need to properly give information to the pathologist, etc., exactly where this came from, because tissue types are different depending on where you are. So, of course, beginning at the top, of course, the mons. There is a frenulum over the clitoris, by the way, just like there is a frenulum over the penis. It's anatomically very similar. Lateral to the urethral openings are the Skene's glands. Start looking for those in clinical. They're the easiest ones to miss. The Bartholin glands don't have quite the dimple on most women that those Skene's glands do. But you'll know when a Bartholin cyst exists because that's swelled up like a golf ball. And we'll talk about that. We already talked about, we were successful in lancing our Bartholin cyst in our practicum, weren't we? Okay. And it didn't even yell at us, did it? Right? So looking at your anatomy, okay, all the way down. Now the clitoris is hidden. When you look at the vulva in a normal female individual, especially of childbearing age or early menopause, you will see just the opening of the glands. You'll just see just the glands, okay? And it should be about the size of a Q-tip. If you think about it, just about the size, give or take, of a Q-tip. When you retract the frenulum, you'll see more of the clitoris, okay? To know, obviously, this is a very sensitive organ. It is only there for an erogenous function. It's not there for anything but an erogenous function. It is a larger complex than you think, and when erect, is bigger than you think, okay? It has two chambers just like penile does, and tons of nerve endings. Again, this just points out the glands there, the Skenes, and the Bartholins. When you have a true Bartholin cyst, it's going to be inside. It really will. It will be inside the introitus there, okay? I do have one patient with a Skene's gland cyst. They're very uncommon. I have one patient, and we leave it alone. It's not bothering her, not bothering us, and we leave it alone unless it changes. Urethra. Well, we got a short one, okay? And I want to point out a lot of things. I always felt a little deficient in urethral and bladder anatomy, so I wanted to point out some things and include this. This is the cutaway. Of course, here's our external urethra, the sphincter that's under our control, mostly. And see this sling, and so this is when they do a sling to help support the urethra, that's where they anchor it, okay? But as we go on up, where the ureteral openings, ureteral jets, and you can see this, it's kind of cool on ultrasound, sometimes you can see these jets when you're looking at the bladder of urine actually streaming into the bladder. But the trigone muscle, that trigone at the base of these urethral openings, is the muscle that's responsible for the, quote, I gotta pee signal to your brain. Right? So the trigone, it stretches and it tells your brain, take me to the bathroom. So those are called the trigone. One can have trigonitis. It is possible. The muscle that contracts the bladder Okay, the bladder itself doesn't have any muscle. It has a muscle around it called the detrusor muscle. And it's under the control of the parasympathetic nervous system. It causes contractions and urine leaves the body, okay? One can have detrusor instability, certain medical conditions and whatnot, causing spasms that can be quite painful. So detrusor instability, sometimes that urge incontinence, the trigone and the detrusor are working against you. It's the I can't get my pants down fast enough function rather than I pee when I sneeze function. So there's two different ones. And again, as we go through our courses, we're going to cover the pathophysiology too, but we need the A and P first, okay? All right, moving further up, the ovaries, they're paired and they're analogous to the testes. They do resemble a large almond, so they're not as big as testes, not at all. But they do a lot of work. There's millions of potential people in there, millions of potential eggs, okay? They produce, of course, the ova, and they also produce 3 sex hormones, estrogen, progesterone, and testosterone. Estrogen, progesterone, and testosterone, which is why I harp a lot about postmenopausal management and post-castration, if you will, taking the ovaries out, BSO, especially in young women, that they may need testosterone and progesterone in addition to estrogen in supplementation. There are 3 parts, and you can figure that out, you know. Cortex, medullary, outer is the cortex, like everything else. Medullary, medulla, and the hilum, okay. Have 2 arteries right off the aorta there. They are sensitive to pain, pressure, just like the testes are, except that they're harder to get pain and pressure too, since they're inside our bodies. But it is a source, by the way, of dyspareunia when those ovaries are touched during intercourse. Fallopian tubes are kind of small, but they are a magnificent organ. We couldn't get pregnant without them. Here's the cross section. And as everything in anatomy, people have to name everything, okay, and divide everything up. So intramural, next to isthmus, ampulla, and infundibulum. The fimbriae, I don't know if you've ever had an opportunity to see this in surgery, but it's just miraculous. It's just marvelous. These fimbriae are like little fingers there, and they sweep, their job is to sweep that egg, the ovum that comes out of the ovary, to sweep that up into here where it's fertilized. And then there's a job of the cilia in here, the hair-like structures, that sweeps it down into the uterus. It's just magnificent, okay? Fallopian tubes, some things can go wrong with them. They can get pus filled, they can get fluid filled, they can be scarred, a lot can happen. But in normal function, ovary here, fertilization, and down to settle into the uterus. So let's talk about that magnificent muscle called the uterus, the myometrium, the thing that can go from 7 centimeters to 40 centimeters and carry 1 or more babies, and then 6 weeks later returns to 7 centimeters. And I don't know which one amazes me personally more. But this is a muscle. It is an involuntary muscle, as we well know. If it were voluntary, no one would ever go overdue, right? So it is a pear-shaped, hollow, pretty simple, but beautifully simple. They arbitrarily divided into the uterine, cervix, and the fundus at the top in the body, okay? It's kind of more important, those anatomical regions, when you're referring to pathology such as leiomyoma or fibroids. All right? The endometrium has actually a double blood supply. And we'll go back to the endometrium in a minute. The vagina, obviously, has many layers. It is, again, the extendability of the vagina is pretty amazing, you will have to admit. And it's built for it by the differences in the layers. Okay. Now, let's leave the pelvis, go up to the breast. In explaining anatomy and physiology of the breast to patients, and sometimes you have to, is to know that the breast is kind of like grapes and stems. The grapes are the lobes and the stems are the ducts. Okay. Most of the breast actually is made up of fat, and most of the lobes are the same no matter the size of the breast. Okay. So the size of the breast has more to do with the adipose tissue than it does with how much milk you can make. All right. Of course, the reproductive hormones are vital to the breast. Okay. Because without prolactin, you can't have milk. You know, without estrogen, without oxytocin, it can't be released. So I think the reason we get the breast lumped in with gynecology is because of the link with the reproductive hormones, probably. And babies go to the breast, or that's what we prefer. The function, of course, is lactation, but it's used a whole lot more for the erogenous area than it is for lactation for most of a woman's life, however. Now, the physiology here, the menstrual cycle. This is a picture that every woman's health nurse practitioner at some point in her career just has plastered in his or her head. Okay. So looking at, of course, what is it? The follicular and the luteal phase. Follicular, developing the follicle, luteal, and you can look at luteal, like luteal hormone, as ripening, so to speak. Okay, and then sloughing if no pregnancy occurs. There's the estrogen curve, progesterone curve, the luteinizing and FSH surge. Now, patients will ask, why don't you draw my hormones? Because I don't know which of these 60 to 90 minutes your hormone is in. Okay, there seldom are hormone measurements helpful at all to you in a reproductive age woman unless you're dealing with reproductive endocrinology, and that's managed in a whole different way. This is what the normal is supposed to be. Now, that pituitary gland is an amazing thing as well. Pretty amazed by the body. Isn't it great that that pituitary gland sits deep in our brain, away from getting hit in the head? It's protected, and there's an anterior and posterior pituitary, controlled by the hypothalamus, and those are the 7 hormones. Not the 7 dwarfs, but the 7 hormones, okay? Most of them, they're pretty important to us, okay? All right, they're pretty important, all right? And they all are stimulated here. Most of them by a negative feedback system. Just for fun, here's some menstrual statistics. Average age, 6th grade, 7th grade, 12 and a half. Menopause, we covered in the other lecture, about average age 51, 52. And the average cycle is 28 days. Menstrual volume, now people swear they bleed buckets, but the average volume is only 50 milliliters, and the average day of flow is 4 to 6. So there's a little link for just for fun. There's no Cochrane evidence. It's just sort of just for fun. I like to throw something in there that's not just plain old hard study for you. All right, so when we're looking at this cycle, okay, when we're looking at how the cycle goes, the follicle, what they call the recruitment of the follicle, happens right after the menstrual cycle. The ovulatory phase only has this 10 to 12 hours. It's a wonder anyone gets pregnant. I mean, really, it's a wonder anyone does get pregnant. And then the luteal phase is from ovulation to menses or pregnancy. 2 types of cells, and the 2 gonadotropins from the where? Anterior pituitary, FSH and LH. By the way, you're born with all the eggs you're ever going to get, but you have plenty. Now, going back to this endometrial cycle, because I'm just obsessed with ultrasound since I did that in my practice also. the proliferation phase, okay, and it begins with a really thin endometrium, okay, the menstrual, all of it's gone out, and this is a longitudinal section of the uterus, tiny 2-3 millimeters. Then it has this beautiful secretory, and it has this absolutely, kind of just pathognomonic of the secretory, that phase of ovulation, when it has this trilaminar endometrium. When one is ovulating, you see this trilaminar. It's not proof of ovulation, but it's proof the uterus endometrium is doing what it's supposed to do in response to the hormones. And then you get this super thick lining right before it sheds. So it's a very busy place. Other changes that occur are in the cervix, fallopian tubes, and the vagina. Those are the cilia of the fallopian tubes, greatly magnified. Looks like something you'd find at the bottom of the ocean, right? Here are the references. Okay, check some of those out. As always, you can call me if you've got questions, etc. And I thank you very much for your attention.